Please welcome our first keynote speaker for the day, James Conyers, CEO of Enlitic. He'll be providing a unique insight into how data fluency can drive meaningful innovation and collaboration across the healthcare field. Please give a warm welcome to James. Come on up.
Is it going?
James, are you here? Are you gambling?
Yes, gambling.
He's gambling. He's getting coffee, he's gambling. Okay. Well, while we hunt down James and see exactly where he's at. Oh, where he's getting his mic. Fabulous. You're not out gambling, James. Okay,
No.
Take it all back. You can have my mic if you'd like.
I think this one's working okay.
Oh, fabulous. Warm welcome for James, guys.
Right. They're working on my presentation, so technical difficulties in a high-tech world. Wait and see where it goes. I'll go ahead and get started. Hopefully they'll get the mic or get the presentation going. Good morning, welcome. I've got a very unique presentation or a conversation that we're going to talk about that I think is maybe one of the most prolific challenges that we face in healthcare. But to give you a little bit about myself so that you just don't know that there's some strange guy standing on the stage and what he's talking about. My name is James Conyers. I'm the CEO of Enlitic. We are a health tech company that builds AI solutions very specifically designed for clinical workflow, capacity, efficiency, and really figuring out how do we help frontline workers. How many of you have ever heard a healthcare IT vendor say, we're changing patient care, we're impacting patient care, right? You hear them say that all the time, right? Well, I got some news for you. Healthcare IT vendors do not impact patient care, right? They like to believe that they do. The fact of the matter is clinicians are the only ones that can impact patient care. The job of an IT vendor is to provide solutions to help them to do that. That's our approach. Our approach isn't to actually impact patient care, but to give the tools to do so. I've been in this space for 25 years. You guys may have know of some of the technologies that I have helped to create over my 25 years. The world's first digital web-based PACS system. Anyone ever know what a PACS is? Picture archive communication. First one, long time ago, so I'm aging myself. I'm lucky I just aged very well. Virtualization in healthcare. Everybody familiar with a company called VMware, right? I helped to virtualize the very first two healthcare organizations in the world with a complete critical care virtualization. We actually built the first cloud-based technology 10 years before Google even had a cloud. And so I've always kind of been passionate about being on the front line of healthcare and innovation. I spent the last 8 years in, still not up, in AI, in healthcare AI, because I know that I had known that the only way that we were going to solve the problems that I've spent the last 26 years myself trying to get everybody else to focus on was only when the technology available to do so was actually going to come about. Right? So I spent the last years doing that. I have a wonderful family, 5 kids, so my wife is even more wonderful than me, because that's why I'm able to come here and to be with you. I'm very passionate about clinical workflows. I believe that we have to use intelligence differently, and there's 2 things that I stand very firmly by. Number 1 is that the answer is always in the clinical workflow. If we really pay attention to the clinical workflow, in any of the 45 plus specialties that exist inside of a health system, you can always find the answer to the solution. And the second thing that I stand firmly by is you can never get an answer if you don't ask a question. It's literally impossible. Okay? So that's a little bit about myself. We'll see how this goes, but otherwise I'll just wing it without my presentation and slides that was going to give you guys this great visualization of data fluency. In healthcare, we have seen it change significantly over the last 10, 20, 30, 40 years. right? We can do complete facial reconstructions. I can give you a new heart, lung transplant, liver. Prosthetics and prosthesis today, you can almost not tell the difference between a robotic arm and a prosthetic. So that's pretty amazing stuff, right? We've come a significant way in medicine. But unfortunately, healthcare is still fragmented. And it's that fragmentation that exists that is the reason why healthcare truly cannot innovate. When I was listening to the panel before, there are so many things in that discussion there that data fluency could ultimately change the trajectory of healthcare. So now it is more important than ever for us to really figure out and to focus on innovation and adoption. But how do we innovate? How do we adopt faster? It's almost impossible in healthcare today. Everything is a piece of a piece of a piece. Point solutions, single pathology-based technologies that solve one tiny problem of a grander scheme, the bigger issue. We do 700 million radiology exams in the United States every single year. But we went and built an AI technology to detect lung nodules. Does anybody know the percentage of those 700 million studies a year that actually are lung nodule exams? Less than 5%. Now, a health system is going to go and spend hundreds, 200, 300 of thousands of dollars to get a single lung nodule to make up 5% of their overall volume. That's really not the problem with AI. That's the problem, the fact that all we focus on is a piece of a piece of a piece. Right? I got to solve this problem. How many of us remember when cell phones first came out? And my cell phone only worked in my region. If I was in Montana and I went to North Dakota, my cell phone did not work. Right? But we fixed that problem, right? I was able to go to North Dakota, but I wasn't able to go to New York. Eventually, we fixed that problem. So there was the point where I could travel anywhere inside the United States and I could talk on my cell phone, but I couldn't go overseas. I'd have to stop and buy a SIM chip, then I'd have to go overseas. Then I'd come home, I'd get a new SIM chip, right? But eventually, I was able to go overseas. Now, we just got the entire world to standardize on a structure and a format. Very interesting, right? But yet we can't necessarily do that in healthcare. We all think that healthcare is full of standards, and that is true. But that is the problem with healthcare. Healthcare has over 4,000 different standards, and it depends on what the vendor decides they want to standardize on. Vendors will take a specific standard, and they will create that standard and make it proprietary. By show of hands, just how many people have heard of the word DICOM? It may be one of the most significant standards to exist in healthcare, but we screwed that up too. Because there are healthcare vendors that have created proprietary DICOM languages, which means one DICOM device cannot actually speak to another. Translation, what gets lost in translation. So if we continue to focus on point solutions, solving one piece of the problem, are we ever truly going to innovate and reimagine healthcare? We're not, ladies and gentlemen. 10 years ago, I sat in a room at another society. I'm not going to say their name. And I was on a panel with a bunch of other vendors. Vendors that if I said their names, everybody in this room would be like, yep, 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 yep. I didn't say a word, I just sat there and I listened. And we were talking about interoperability. 26 years ago, when I started in this business, we were talking about interoperability. right? That was 15 years after I started. We were talking about interoperability. And I listened to these all these vendors, you know, kumbaya, love you, got you, great. Good to go? Excellent. And so we started talking about, now let's hope that I know how to advance. That's not the right presentation. But there's my cell phone slide. Right? Sorry, that's not the right presentation. We can just skip the presentation, that's okay. I'll just sit here and talk freehand on it. More than happy to share it with anybody else afterwards because there's a lot of great information in there. But I sat on that panel and I listened to everybody talk kumbaya. We're all going to get on the same page. We're all going to talk the same language. And I sat there for about 25 minutes and never said a word. And I'm unfortunately that individual that's pretty blunt and speaks my mind and gets me in a lot of trouble, especially with my wife. But I just giggled and I laughed and I said, "You're all crazy." And everybody in the audience kind of gasped. I said, if you think that we are all going to get on the same page, speak the same language, and a language that we understand in our lifetime, we're all idiots. Because it's the truth. Now that was 10 years ago. So if they were right, then that problem's been fixed in a decade, right? We are no closer today than we were 10 years ago to solving this problem. No closer. Let's take another example. How many remember when Apple device came out for music? Yeah, I remember that. Maybe one of the most simplest devices in the world, and I couldn't figure out how to use it. But if I bought music for Apple, I could only play it on Apple. But if I went to another site online and downloaded a piece of music, I could not play it on that Apple device. What did Apple do? They locked me into Apple. They created an environment in which Apple is Apple. Apple is cool. So how many of us in this room today are Apple users? How many of us are like, Apple is the greatest thing in the world? How many of us are Droid users? We created silos. We created segregation by the vendor themselves because they want to control the data. There was a very, very intelligent man, and none of you will have ever heard of this individual because he was way, 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 way down here on the totem pole at Google. And I heard him walking down the hallway one day when I was out on the Google campus, and he said, "The sad world we live in. He or she who owns the data owns the world." So do you really think the vendors want to solve interoperability? We've been dealing with it for 40 years. So the question and the answer to that is no, they do not. How many have heard of fire? Fire is going to save the world. Fire is going to change everything. Fire is the transfer mechanism. It's a communication protocol, right? It's a web-based one. It takes HL7 and says, hey, we're going to web-base HL7. I'm going to be able to communicate with anybody anywhere in the world. But what if the system doesn't actually give me access to all their data? It doesn't matter, right? The whole concept of data fluency is literacy. If I go to my 4-year-old daughter and I give her the Odyssey, how much of it is she going to understand? Not that much. She won't understand the words. She may not even be able to comprehend the point of the story because she hasn't learned literacy to the point that she could literally comprehend it. And that's the whole point of data fluency. It's the whole point of literacy, is that data without context is just data. It has no value, it has no meaning. Now, I can go on another example before I really get into the meat of this conversation. How many of you have different banks and different retirement accounts in different places because you've worked at different facilities, and now you've got your Bitcoin stuff over here in this wallet and then a different one in this app because I have to have a wallet on this one, but I can't buy this one on this over here, right? We've all got that going on in our world. But there's an actual app that I can download on my iPhone or my Apple or my desktop that can consolidate my entire financial picture into one single application. Now I can see it from whether it's JP Morgan or Fidelity, wherever, in one application. Now what am I able to do with that data now? Now that I can actually see it, I don't have to go log into Chase or log in over here, download this spreadsheet, merge this spreadsheet, run a query on this spreadsheet, sort this spreadsheet, create my own graphs. I can now make meaningful, relevant, in real-time decisions about my future, my financial health, and that of my children in one application. Gosh, it doesn't seem hard, does it? Right? It doesn't seem like it's rocket science. But we make it rocket science. Right? That's what we do. So I just gave 3 examples that are global phenomenons in which we on a global scale have solved data fluency problems. But yet we cannot solve it in healthcare. So some of you might be like, what do you mean we can't solve it in healthcare? Let me give you some real world examples. I'm a physician, not literally, but let's pretend that I'm a physician today. I've got a patient, young lady, 30 to 35, Hispanic background, has a lung nodule in her upper left lobe, 3 millimeters in size, and being treated with a very specific kind of drug, the drug treatment that I prescribed. But I want to make sure that the care that I'm giving that individual is the best possible care that that person deserves. So I walk into the local the hospital, and I say, can I have all of the data that you have for females between the ages of 30 and 35 of a Hispanic background that has a positive lung nodule greater than 3 millimeters, and I do not care which lobe it is on, that has been treated with these 5 different drugs for the past 25 years, and I want it in 10 minutes. Can I do that? I can't do that. How can I not do that? How can I go to Japan with a phone and have a conversation for hours with somebody who speaks 0 English? But I can't get something as simple as that type of population health-based data. 0 cents, ladies and gentlemen. One more example. Let's say that I'm an oncologist in a small town in the Midwest, right? And I'm treating a patient with stage 3 breast cancer. That patient is never going to have the opportunity to go to a prestigious healthcare organization like a Mayo Clinic or a Cleveland Clinic. But does that young lady deserve any kind of different care? That's not fair. I don't care how we look at it. It doesn't matter where I live. It doesn't matter what my lifestyle is. I deserve the same type of treatment. So why can that oncologist sitting there treating that patient have access to every other female that meets that same demographic and population health right at their fingertips, instantly? It's because the data that we have, ladies and gentlemen, in healthcare is malformed. It is missing. The answer is not the EMR. It was not designed to handle whole slide imaging, pathology, genetic-based data. It was designed to be fed the right data, to link that data. So FHIR isn't going to solve this for us, right? Think of the devices, the medication that we could create if we had more data. Think of the mental health stuff that we were just talking about, that if I could collect this data on a national scale, could I treat individual mental health patients that are experiencing the exact same symptoms in the exact same type of demographics differently than I treat somebody else? That's how we change the world. That's how we reimagine healthcare. AI has changed that for us. What was impossible yesterday is now possible today. We can use AI to create a universal ontology, a common data model that is understood no matter where I am in the world, and to be able to take that data and translate it into a context that's understood by any system in any of the 45 clinical specialties that exist. Which means I now have the right data at the right time for my specific patient. How many have ever heard of peer review? How many people have ever heard of a radiologist complain about peer review? Because we slow down their ability. We've got capacity and efficiency issues, ladies and gentlemen, in the world. We just heard about it from the mental health. There's not enough. It's not going to change. It is the #1 global challenge in existence today, efficiency and capacity. Am I going to solve that with a lung nodule AI algorithm? I am not. I'm going to solve it by building intelligence into the clinical workflow to simplify, to automate, to validate, and to ensure I have the right information. How many of you, if you were a radiologist or know of a radiologist, that forget peer review, it's completely eradicated. And when I sit down to read and I pull up a male, 46 years old, 6'3", 220 pounds, lives in the Midwest, eats way too much meat, and I'm reading that study for that patient and something pops up and it says, based on this patient, based on this criteria, the demographics, the information, everything provided to me, the best possible treatment plan for this patient is A. Or, based on this procedure, this chest CT, 96% of the time this is missed. That drives down error, drives down risk, improves patient outcomes, okay? So that, ladies and gentlemen, is data fluency. We need to start focusing on that in our organizations. We need to start driving data fluency. We need to start pushing the fact that we have got to take it in our own hands and say, I don't care what the big vendors say, right? This is our policy. You allow me access to my data, which is my patient's data. You allow me to put it to whatever universal structure and common data model that I see fit for my local population and my demographics. And we start using intelligence differently to solve the world's problems. And I can guarantee you this, by doing that, you solve the problem at its core. You solve it outside of the clinical workflow. So before it gets downstream and screws everything else up, fix it here, and you will solve dozens of the most significant challenges we have faced for the past 40 years in healthcare. I guarantee it. And if I am wrong, I will give all of you my personal information, and you can call and tell me I was wrong. But we have already proven it, that it's true. So I know it's not wrong. So as you move forward and you leave here today, and every discussion and conversation you hear throughout this week, think about literacy. Think about data fluency. Think about, does the data impact what I'm hearing? Because the answer is where? Always in the clinical workflow. Solve it for the frontline workers, change the world. That's all I have. Sorry you didn't get to see my cool presentation that I spent the last 48 hours straight, no sleep, no food, no nothing, slaving over, but that's okay. That's okay. I'll open it up from some real quick questions because I know we're just about out of time. So if anybody has a question or would like to ask a question, now would be the perfect time to do so. It's actually a combination of provider, OEM, and eventually even payer. Because we want to be agnostic in everything that we do, right? If I try to drive it just at the provider, then the payer is going to say, well, I'm going to go do my own thing, but then how do I even bring the vendor in? Remember that panel I said that we had? I've got to include everybody, right? And we've got to drive it with everybody. Mm-hmm. Yep. Sometimes we don't even know what the data is that we need because we just haven't had the data. Mm. Yeah, you know, what's very interesting about what this young man up here in the front said was, we don't know what we want because we've never had it. I have replaced PAC systems, over 2,000 PAC systems around the world. I've been privileged to see clinical workflows from just about every culture that exists. And I've walked into clinicians and techs, and I go, well, why are you doing this? Well, that's just the way it is. And I go, but what if you did this? And they're like, no, that's not possible. I'm like, well, actually it is. Yes, ma'am. Yes, a very, 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 very good question. A lot of these communication barriers that we have, a lot of everything that we think we know is manifested. It's something we have actually created, right? If we actually fix the data interoperability, standardization level outside of those clinical workflows, it drives the communication strings downstream effectively and efficiently. Which also now allows me that if I'm talking about, you know, my post-acute care, or I'm at an ACO, or if I'm in a community hospital or provider environment, I'm able to transfer information meaningfully, which means I don't have things lost in translation. Great example of what you're talking about, of how do I go from here down and make sure that that communication happens. How many people have heard of the follow-up problem? Ladies and gentlemen, this is insane. That this literally exists. As a radiologist can sit down and say, I highly recommend that this individual have a follow-up in 2 months. That follow-up doesn't happen. That patient dies. This happens. But if I had that information, my communication path is fine. Because I should automatically be able to give that to the provider, give it to the patient, and then follow-up happens, tell the patient engagement system, hey, schedule the darn thing, and then pester the crap out of it until it happens. And if it doesn't, then show up at their door. That's how we solve all of those problems. I can give you 20 different ways to zero, and I will go over here, and I'm more than happy to talk about this. I could talk about this for years. But these people over here are telling me if I don't get off, they're gonna break my knee.
Yes, unfortunately, we're out of time. So,
like
guys, please
knees.
give it up for Mr.
Thank you.
James Conyers, CEO of Inlytic and one of our gold sponsors.